Hello, my name is Adam. I will be demonstrating how to do an assessment with a patient that has a chest tube. So, we're going to enter the room and meet Jennifer. Good morning, Jennifer. My name is Adam. I will be your student nurse today. I'm just going to shut our door here, give us some privacy. Could I get your full name and date of birth? She tells me Jennifer Doe. Date of birth, 11/5/1975, so that checks out. So, my CNA took your vitals, we checked your oxygen saturation, and your oxygen saturation is right where we want it. That's very good. Are you in any pain at all? She says she is. She rates her pain a 4 out of 10. If before doing my assessment, I might want to go grab some pain medication and administer that before doing my assessment. So we're gonna I need to listen to your lungs and all that. Are you comfortable right now? She tells me she's comfortable. She's just sitting in a semi-Fowler's position. It's good to know, which it helps with promotes drainage with our chest tube. So have you been having any difficult breathing at all? She says no. So, what I need to do right now is I need to listen to your lungs. Is that okay? She says that it's fine. Okay. Okay. So, I'm going to listen to... I'd be listening to all fields for the right amount of time here. And then I'd have them be sitting up so I can listen to the back. So if they're able to do so on their own. And I do the same on the back here. Obviously I'd be documenting any adventitious breath sounds that I heard. And I'd continue through each field here for the right amount of time. Very good. Have them sit back, comfortable position. Okay, are you... So I'd also be looking for some cyanosis, labored breathing. I'd be looking for abdominal breath sounds are normal in a newborn up to 2 years, and I'd be looking for labored breathing, shortness of breath. She says that she's feeling fine. So all right, so Jennifer, I'm going to take a peek at your dressing. Okay. So I'm going to wash my hands here. Just in case that when we are observing our dressing and our tube, if any dislodgement, I'd make sure that I have some extra materials in here. I'd have my saline, my normal saline, if they became dislodged, I'd want to submerge the tube into some water to re-administer that air leak. If there was dislodgement, I'd want to what it would do is give another air seal to the chest tube until we can get that fixed. So I also have some more foam dressing, some Vaseline sponge, and drain sponges and stuff, okay? And I'd also have a hemostat as well. So, okay, I'm just gonna pull up this side right here. Take a look. So first off, I'd observe, I'd look for any shadowing or drainage around and seeing, obviously I'd be documenting that if any, and I would be palpating for some crepitus, so not touching right at my insertion site but around it, palpating all the way around, even up into the neck. Would sound like Rice Krispies if I did, and asking if they're having any pain or anything around here. Later we would be changing the dressing. We'd be checking our Coca and Rita to our site. All right, so next Next I'm going to look at my tubing here. I do not want any dependent loops at all, so looking at my tubing going down. In this case, obviously there is, so we would make, we'd make our coil, okay? So I'm looking to see on the patency of my tube if there's anything that's built up in here, okay? If I would assess for an air leak, I would use my hemostat, and then assess for my air leak, okay? So coming down into, I'm also going to make sure that our drainage system is below the body, okay? Making sure it's upright. I'm looking for any break in our seal here, making sure that we're open, which we're open. Making sure it's not clamped, making sure that our seal is not nice and tight here. I'm looking at our, on here, I'm looking to make sure that we have our negative 20 pressure, which it is, making sure that we have at least, since this is hooked up to water seal, making sure that we have at least 2 centimeters of water. If not, I can add some normal saline to that. I'm going to look at my drainage, how much drainage we have in here. If they're having greater than 100 milliliters an hour, we're going to want to notify the physician. And if we have any bright red drainage, we're going to want to notify the physician, because that's an indication of active bleeding. We're going to want to document our color, consistency, and the amount if we have any in here. Okay. So also we're going to make sure that if our suction is hooked up right, and looking at the suction on the wall, making sure we're at the appropriate amount of suction that we need it to be at. Okay. Let's see here. So I'm going to take my gloves off. I'm going to wash my hands. So making sure that they're comfortable, making sure that they're using their incentive spirometer, making sure we're going to need to try to move every couple hours, obviously to your ability with, your pain level. But that's obviously very important for the lungs. So I document that with using the incentive spirometer. I'd be documenting the amount of drainage that I have, any assessment findings, with the lung sounds, the respiratory status, their vital signs will be documented, their oxygen status, our saturation, and any drainage that I see on the dressing at all. Maybe some, the coca that I would see, any crepitus that I found. We would only notify the physician if there was, we'd mark the crepitus if there was any. If it continues to get worse after reassessment, then we'd notify the physician. Otherwise, I'd make sure that we're safe. They're in a semi-Fowler's position. That helps promote draining, and making sure they have their call-light, low bed floor mat, clean up my area. And this concludes my video.